Good evening, everyone. Good evening, everyone. Can you hear me?
Yes, we can hear you.
Right. Thank you so much, sir.
Yes, we can.
Okay. So it's 5 minutes past 8, and I think we can have an early start to this event. Good evening once again for everyone for joining us in this event. My name is Ademola, Adeyeye, parent of Nigerian Society of Colorectal Disorder. And today, for our monthly meeting, we have an erudite member of this society in the person of Professor Emeka Ray-Offor, who is here to speak to us about the advances in rectal cancer surgery. Professor Offor is of the College of Health Sciences, University of Harcourt, and also the Director of Minimal Access Program of the same institution. He's also the head of the Colorectal and Minimal Access Unit of the Department of Surgery in University of Harcourt Hospital. He also has many other titles, which I will not want to belabor us with, but we can see that on the screen. But we can all agree that he's quite suited to make a good presentation on what we have to speak about today. And like I've said, we are looking at the recent advances in rectal cancer surgery. We have our elder in the house, Professor Emmanuel Gwari, who will be our rapporteur and help us coordinate the events. Again, please have your questions and comments ready, and they can be posted on the chat and as well as by voice at the end of the presentation. We will share a link for attendance, which helps us to keep track of activities. And without further ado, I'd like to hand over the stage to Professor Ray-Offor.
Thank you very much, my president. In the next 45 to 50 minutes, we'll be talking about advances in rectal cancer surgery. My screen has frozen. Okay. I have no conflicts of interest to disclose. The learning objectives for this talk is to understand the notable advances in rectal cancer treatment and to highlight total mesorectal excision and sphincter preservation, and to emphasize minimal invasive surgery techniques in rectal cancer surgery. And then lastly, for us to go towards the national recommendation towards optimal care of patients with rectal cancer. So the rectum is the last part of the large intestine, and it's crammed in the pelvis by very important structures. And when cancers are involved, there is that high likelihood of infiltration of nearby structures. Traditionally, you had the 5 cm distal resection rule, which almost invariably led to permanent stomas, but with advances that has reduced drastically from 5 cm to 1 cm or less than 1 cm from the sphincter complex. With better understanding of tumor biology, mismatch repair deficiency, MSI, age, and PDI blockade, there have been advances in treatment that have made surgery, which is usually the definitive treatment, a lot more feasible. And this has reduced recurrence rate. So what are the advances I'm going to talk about? Preoperative planning, neoadjuvant therapy, total mesorectal excision and sphincter preservation, minimally invasive rectal cancer surgery, fluorescence-guided surgery, and then selective lateral pelvic lymph node dissection. So cancer treatment generally, and rectal cancer in particularly, has evolved into a multidisciplinary team management. And this is very well modeled by the North American National Accreditation Program for Rectal Cancer, which encourages a unified group of experts, surgeons, pathologists, radiologists, medical oncologists, radiation oncologists, and there are metrics that are monitored when an institution is accredited, and all are geared towards optimal healthcare. I'll try to be as evidence-based as possible in the rest of this presentation so that you wouldn't just say it's me that said it. So here is a clinical details template that we adopted from Cleveland Clinic, Florida in UPTH. You're able to, we have our regular meetings every Tuesday morning, and we discuss any cancer patient that is due for surgery or restaging, and a decision is taken, and optimal care is given to the patient. So in terms of preoperative planning, I want to emphasize in the imaging, I want to emphasize magnetic resonance imaging. A previous talk by a consultant radiologist shed some light on it, but I just want to emphasize it. The Mercury study, which kind of brought to fore the importance of MRI assessment, shows that when you preoperatively assess this circumferential radial margin, and there is no involvement. It is a significant parameter for overall survival and disease-free survival and local recurrence. So the table shows that patients who are MRI clear of involvement of the circumferential margin have a higher overall survival, 62.2% as compared to 42.2%, and then local recurrence, 7.1% compared to 20% in the MRI involved. Now, MRI also is a predictor of disease-free survival, in the sense that this study highlighted that it is a multi-center randomized control study. Patients had MRI treatment before the rectal cancer, before chemo, 4 weeks after induction chemo, and after completion of the chemo. And from multivariate analysis, it's showed that in terms of relapse, that the independent risk factors were the ECOG performance score, sphincter involvement, MRI, extramural vascular invasion, and early tumor regression. All these are accessible by MRI. So there's need to emphasize an MRI assessment of all rectal cancer patients. And also need to emphasize standardized reporting. This is a template from the Society for Abdominal Radiology guidelines. MRI is critical to assessment and staging and restaging, and the T2 weighted imaging is the sequence of highest importance. So with this template, the radiologist improves their skill by selectively going for this information and documenting them, and for the surgeons to make a decisive decision regarding the treatment plan. So another concept is neoadjuvant therapy. Multiple trials have been done. The OPRA trial initially was the one that tried to assess preoperative chemotherapy, comparing it with adjuvant chemotherapy. And this showed that the preoperative chemotherapy had a better outcome. And then the PRODIGE 23 trial emphasized the effectiveness of the modify for FOLFIRINOX regimen, given neoadjuvantly. And then the OPERA trial compared the divided patients into a consolidation group and induction group. By that, I mean the idea of giving radiotherapy and then a consolidation chemotherapy before surgery, and then the other arm induction giving chemotherapy and then radiotherapy before surgery. And this showed that the consolidation arm had a better outcome in terms of clinical, pathological clinical response. The PROSPECT trial emphasized that FOLFOX regimen was non-inferior to preoperative chemotherapy. So all this put together birthed the concept of organ preservation for that's giving the full course of chemo and radiotherapy before surgery. And for locally advanced rectal cancer, this goes a long way to downstage and in many cases give complete clinical response. Another neoadjuvant therapy is immunotherapy, the PD-1 blockade, which unlocks the anti-cancer effect of the T cells. This is the magic drug, the dostarlimab. The jury is out there regarding the second of this phase 2 trial that compared dostarlimab monotherapy in patients with untreated stage 2 and 3 MMR and MSI locally advanced patients. So, coming to rectal cancer surgery, what are the important considerations? The tumor size, early rectal cancer, the options of local excision and radical surgery. We'll talk a bit on all of this as the discussion progresses. The distance from the anal verge and anorectal ring is preferable to assess the distance from the anorectal ring, which is the sphincter complex that injury to that will lead to incontinence and with variations in anatomy. And the use of anal verge is less encouraged. And the current thinking is the distance from the sphincter complex is a lot more pertinent. Orientation within the lumen, as we'll talk about, advanced transanal excision technique of TEM, that's a transanal endoscopic microsurgery. We'll get to understand that depending on the orientation within the lumen, that will decide the position of the patient. Circumferential radial margin, I tried to say a bit about that earlier. Extent of obstruction, now you have elective cases and the obstructive cases. When there is a luminal obstruction to the extent of obstipation, then the patient requires an emergency surgery. Extent of fixity to the rectal wall going towards locally advanced rectal cancer. Generally, you have local early stage rectal cancer, locally advanced, recurrent, and then metastatic. I'll leave the discussion for metastatic for another day. Degree of sphincter involvement and then sphincter tone. I'd like to emphasize this important concept as the total mesorectal excision, as the idea of staying within the plane between the mesorectal fascia and the presacral fascia, and the total extirpation of the mesorectal fat with the introduction of this by Bill Head. This reduced the recurrence rate and also emphasized the need, the possibility of having less than 5 cm distal resection margin, so long as the entire mesorectum is cleared. So wherever you have rectal cancer surgery, the ultimate goal is to preserve the sphincter. Stomas have their complications and challenges, and many patients have religious and not they have cultural beliefs regarding that, and so wherever it's possible, patients would gladly prefer such. And this slide shows the various levels of resection, where it is at the pelvic floor, as just at the pelvic floor, that's your very low anal anterior resection. And then just proximal to the dentate line as a partial intersphincteric resection. And this intersphincteric option is only advised when there is no involvement of the external rectal sphincter complex. If it's just involvement of infiltration of the rectal wall muscle, and it's quite feasible to, within the plane that separates the internal muscle and the external, to have a resection and have it as low down to the dentate line, below the dentate line. And then the blue slides to the side is your extra levator AP resection. So this study emphasizes that it was done, a randomized control study done between 1995 to 2002, preoperative chemotherapy followed by TME. This was a Greco-1 trial, and then 799 patients were analyzed. 10-year overall survival was better with patients who had anterior or intersphincteric resection. That's a 63.1% compared to that of AP resection, and this was statistically significant. And this goes a long way to highlight the importance of sphincter preservation. Now, after doing very low resection, there's reconstruction. There are different reconstruction techniques. You have that coloplasty, straight repair side to end, J-pouch. This meta-analysis says that it didn't find any superiority for any of the techniques in terms of anastomotic leak. But like you know, generally with literature and evidence, you have those for and those against. This other one, comparing the J-pouch versus the end-to-end anastomosis, actually, it was 27 studies reporting 3,293 patients. That's a high-powered study, and showed that anastomotic leak was higher with the straight compared to the J-pouch, and reoperation rate also was higher. It also goes on to show that stool frequency per 24 hours at 6 months and 12 months was better with the straight group. And then use of antidiarrheal medication at 12 months in the J group was a lot more reduced. We go on to the next area of discussion, minimally invasive rectal cancer surgery. This is actually the area I love to talk a bit more on. And we would like to talk about laparoscopic versus robotic surgery. And then the newer advanced transanal excision techniques, that's rigid versus non-rigid platforms of your transanal endoscopic microsurgery, transanal endoscopic operation, and then transanal minimally invasive surgery, and TATME, transanal total mesorectal excision. We'll get to talk about that in a moment. So this study, our study actually kind of demonstrates the textbook approach to laparoscopic AP resection. After the key thing in rectal surgery that any rectal surgeon dreads is anastomotic leak. So the quadruple assessment of the anastomosis is advised. That's your leak test done, air is insufflated, and the pelvis is filled with water, with saline, and the anastomotic area is dipped into it, air is insufflated. If it's
It appears we've lost our speaker. Let's be patient for a minute.
hello,
Hello.
are you hearing me?
Yes, we lost you.
We lost you. Yeah.
Really sorry about that.
Yeah, we lost you at the time you were speaking about the air leak tests.
Okay.
Yeah,
All right. So I talked about the quadruple assessment of anastomosis.
Yeah, you have to reshare your slides, sir.
Really, it's not showing?
No, it's not.
Really? Okay.
Yeah, we just lost it at that quadruple assessment slide.
Okay, I would get it back up. Sorry.
It appears you've paused the screen sharing in case you are wondering if it's up or not.
I did. Is it on pause now?
Yeah, it's showing pause.
You could stop sharing and then reshare it.
Okay. I'll do just that. Sorry about that.
Yep, we are back.
Okay. Okay. Yeah. So the quadruple assessment test, air leak tests, use of your dye, having an endoscope, a colonoscope in theater, do an inspection, endoscopic inspection, and then checking the two donuts. In the center where this study originated from, prophylactically, all patients have a urethral catheter inserted, and then through which the indocyanine green can be injected to outline the ureter. We'll talk a bit more on ICG. And then the use of large vessel ligators, energy devices to ligate the large vessels, and then typically a high ligation of large vessels are done. So this is like a textbook surgery. Now, this, I included this because it's a large database, 18,255 patients. A textbook operative outcome was negative distal resection margin and circumferential resection margin, retrieval of more than 12 or more lymph nodes, no 90-day mortality, and length of stay less than 75% percentile of corresponding years range. And then predictors, independent risk factors identified from multivariate analysis show that increasing age, non-private insurance, and low volume centers, they need to emphasize volume of cases done. As we go on, I'll emphasize it a bit more, and then it will play a role in my recommendation. Comorbidity index and the APR resection, all of that. Now there are a lot of high-level data comparing laparoscopic versus the open approach. That's the color trial. It emphasized, it compared laparoscopic and open group, and noted the benefit of shorter recovery time, bowel recovery time, shorter hospital stay, and the only downside was longer surgery, longer operating time. The rest of the other indices were similar. The other randomized control trials, ACOSOG, and then the Australasian laparoscopic cancer group, all go to highlight the advantage of laparoscopic surgery over open in terms of, or I would say the non-inferiority in terms of disease-free and overall survival. My screen has frozen. Okay. The next thing to talk about, robotic surgery. Now, there are different robotic surgical systems in the market currently, but of all of them, the Da Vinci system has played a dominant role, and even more so currently, you have the Da Vinci 5, an improvement on the XI, but generally you have different differences in these robotic systems in terms of the arm, in terms of it being immersed, that's the operating, the operator being in an immersive state, like the first image to the far left. That's the surgeon immersed in the surgical field. You have other systems like the surgeon is not in such position. Then those that have modular arms, like this Versus, I put an image here. It has 4 separate modular arms, and then that's compared to the Da Vinci, which has all coming from a boom. There are other subtle differences, but I must say there are newer products that are coming into the market that will reduce the dominance of the robotic surgical system. Here I showed a slide on laparoscopic, robot-assisted laparoscopic anterior resection, where you have the arm the port to the right hypochondrium is the assistant port. Then then you have the optical port at the umbilicus, and within at least 8 cm distance on either side of that, you have the R1 and the R2, and then there's another port in the right, in the Palmer's point. Okay, there are different surgeons would choose different port placements, but these are common port placements for robot-assisted lap anterior resection. The introduction of robotic system in colorectal surgery has found a critical role in rectal cancer surgery because of the narrow space and better manipulation, increased degree of freedom with the robotic platform, and also a stable platform, reducing surgeon assistant fatigue and tremor with the running of the camera, mesh repair, and then right colectomy. But our discussion today is on rectal cancer surgery. So I just wanted to emphasize that. Now, data available, an RCT, the roller study, roller trial, compared laparoscopic resection with the robot assisted. It demonstrated that surgeons with varying experience with robotic surgery were involved in this trial, and 471 patients were randomized, 234 laparoscopic and 237 were robotic in different sites, multi-center, 10 countries. The conversion rate for the laparoscopic group was 12.2%, and the robot-assisted group was 8.1%. And then the circumferential resection margin was 6.3 for laparoscopic and 5.1% for robot-assisted. Despite the reduction in this, the reduction in the values, it wasn't statistically significant. So one would say that the data, the high-level evidence is yet to back the overt use of robotic surgery systems, which has really caught fire in high-index countries. You have, in fact, is right now, if a hospital doesn't offer it, is a big disadvantage. But all said and done, with the cost reduced, I believe it's a good thing for rectal cancer surgery. Now, this propensity score matching study was comprised 21,415 patients, and robotic surgery was seen to have a lower conversion rate. But we look forward to more randomized control studies that would emphasize the benefits. But so far, it can be said that robotic surgery, that's from high-level evidence, is non-inferior to laparoscopic anterior resection. Now, coming to advanced transanal techniques. Now, you have the transabdominal and you have the transanal approach to rectal cancer, depending on the location, as I had talked about. Now, this is offered to early stage rectal cancer, which is within 8 cm and above from the anal verge. And the criteria above less than 30% circumference of the bowel, because if you do too much resection of bowel circumference, you might have, when the healing, you might have narrow stricture formation and all of that. Less than 3 cm, mobile, not fixed, and no adverse unfavorable histology like lymphovascular invasion or poorly differentiated tumors. Those are not candidates. And then perineural invasion, those are not candidates for advanced TAE. So basically, you have it for T1 cancers, but in recent times, T2 with N1, they do neoadjuvant and then downstage and then offer T1, all with the intent of reducing the morbidity that is related to TME surgery. Now, yes, technically, it's a superior surgery in terms of disease of recurrence, in terms of reduction of recurrence rate, but it has morbidity, significant morbidity attached to it, including sphincter challenges after surgery. So I'll briefly want to compare these systems. The image on the top right corner of my screen kind of like captures the rigid and the soft platform. The image to the right is the soft platform. That's the transanal minimally invasive surgery, where the device has a shorter length, and this improves the manipulation angle of the instruments, as can be seen, compared to that of the rigid, the transanal endoscopic microsurgery, or the TEO, but with in experienced hands, surgeons are able to do surgeries that offer patient less morbidity and tissue complete specimen retrieval. The difference between the TEM and the TEO is that the TEM has a micro surgery mount and a rigid proctoscope, which is beveled. And what I said earlier about the location of the tumor within the lumen. Now, because of the way it is fixed, rigid, and configured is such that it can only operate on a tumor in a dependent position. So if the tumor is anteriorly located, the patient has to be put in a prone position to perform that surgery, to have that anteriorly located tumor in a dependent position for visualization by the surgeon. And it has special instruments, unlike the TEO, which has a rigid platform, but which uses regular laparoscopic instruments and a special camera. I've already talked about the soft platform. That's the TAMIS platform, which has a device, a multi-port device inserted into the anal canal, and that's an image of what it looks like. This is another interesting study of ours, which compared transanal minimally invasive surgery and rigid platforms, 931 patients and seven studies. The findings was that the operative outcome and specimen quality for local excision using these techniques were similar. The choice of the platform should be based on availability, cost, and the surgeon's preference. Still on the transanal surgery is the newer transanal total mesorectal excision, which is more like a combination. It has evolved. It's not exactly a revolution, I would say it's an evolution because it's born out of a concept comprises total mesorectal excision, intersphincteric surgery, and then use of a transanal platform. Now, it is a bottoms-up approach. Now, TME, the surgeon operates all the way from the abdomen and does the pelvic dissection, which we say the robotic surgery with the increased degree freedom of the arm and the stable platform, and then 3D imaging and all the advantages that it offers help to improve transabdominal surgery. But for mostly low-lying rectal conditions, there's also that prospect of doing a dissection from below and combining it with the transabdominal surgery using a rigid platform. Prior to this was the transanal prior to this was a TATA, which didn't involve using a rigid platform. It was simply doing the equivalent of an AP resection, doing the abdominal component, and doing an intersphincteric transanal component, and that way trying to preserve the sphincter. So more and more studies are coming out on the benefits of this, and I must say that it has a very significant role in low-lying rectal surgery. Another concept I want to emphasize is fluorescence-guided surgery. This typically indocyanine green is injected. This is bound onto plasma protein. And when you apply near infrared light, it fluoresces. So this image clearly demonstrates a laparoscopic anterior resection. The anastomosis is tested. The perfusion is assessed as one of the modalities for assessing for the competence of anastomosis to prevent anastomotic leak. What does the data say? Now, the two on my left, the essential trial and the pillar trial, demonstrated that in more times than others, that it was able to alter the point of an anastomosis based on the identification of non-perfusion, but in all, it didn't demonstrate its ability to prevent development of anastomotic leakage. Another use for the fluorescence imaging is for lymph node detection. Now, this study compared the ICG group and control group, and then in patients who had D3 dissection, is the Asians high up on this end in lateral pelvic wall, sidewall dissection. And it shows that indocyanine green was increased the ability to harvest nodes, and but there was no significant difference between these groups in terms of detection of positive lymph nodes. He was able to detect more lymph nodes, but when subjected to test, there was no difference in the detection of positive lymph nodes. Yet another usefulness of this imaging is the urethral catheterization. Like I had mentioned, if a urethral stent is inserted and the dye injected, it guides the surgeon and reduces one of the major complications that can arise from laparoscopic anterior resection, which is injury to the ureter. Lateral pelvic wall dissection, like I said, the Japanese especially, are far more advanced in this, and this trial showed non-inferiority of mesorectal excision alone to mesorectal excision with lateral lymph node dissection. And there was a lower recurrence rate with the group that had a lateral lymph node dissection. So my recommendations: centralization of cancer treatment to specialized centers. Now with volume, time would not permit me to share more slides than I have, but there's ample data to demonstrate that with volume, there is a lower recurrence rate with volume. Another important thing is cancer registry. From the NDT or from the established cancer registries, they need to be updated. They need to be, there's surveillance of patients. I don't know of any study locally that shows survival from these cancer patients. Now that requires, one, you have the registry and being able to follow up 2 years, 3 years, 2 years overall survival, 5-year overall survival. I don't know of any center. I don't know of any registry in our setting where such data has emanated from. Now, I've dwelt with minimally invasive surgery, and there's need to highlight the need for that. It's capital intensive. You need a dedicated MIS theater, and then a facility for on-table colonoscopy, as I've said, consumables and technical support, and training and research. Training, I've had my fair share. This was in Dundee, the European Association of Endoscopic Surgery, Laparoscopic Lower GI course in 2014. There, seated in the middle, is Sir Alfred Kusheri. To his left is my good friend, Professor Luigi Boni. To the far left is Kevin Campbell, recently in Cleveland Clinic. To the left is to a legend, was the legend, Professor Stephen Wexner, who's the director of the Lefa Schumann and Stephen Schumann Digestive Disease Center in Cleveland Clinic, Florida. He also happens to be the chairperson of the National Accreditation Program for Rectal Cancer in North America. In conclusion, personalized multimodality care is the way to go. Rectal cancer training is required. Specialized centers and volume are needed for competence. Minimally invasive surgery techniques are to be emphasized, and training, again, I mentioned training and research need to be emphasized. Thank you for listening. Here are some surgical textbooks for training. The one in the middle is impressed from the timeline of publication. It should be out on the 24th, I believe, 24th of August. And the one to the far right there is in the draft stage for the second stage. Once again, thank you for listening.
Thank you very much, Professor Offor. Thank you so much for that fantastic presentation. And I think it was quite all-encompassing, and you dealt with every aspect of the treatment of colorectal cancer, and you've practically gone from the historical to the contemporary. So we will welcome questions. If we can stop the slide share so that we can see all the attendees. The other thing I want to say is just to commend the dedication and the sustenance of the interest. Currently, there are about 89 people on the platform, which is a record, to have this consistently, month in, month out, I think is to be commended. There are very few meetings all over the world that you have that kind of consistent attendance, upwards of 70 at most meetings. So I want to just commend the association for sustaining the interest of members over the past few years. And again, it's just a testament of the interesting and interactive topics or relevant topics that you profile for discussion. So I congratulate the executive also for putting together a great show every time. Thank you so much. So I will go to I will just look through the charts to see the questions. Professor Ray-Offor, I just want to start. You went through everything. You started from the biology, and you talked about the tumor modalities, and in terms of the size, resectability, fixity, and distance from the inner verge and the dentate line and all that. I was just wondering, what combination of parameters, or what are your modalities? What parameters govern your modality of treatment in UPTH?
Okay. What I've said is I've tried to incorporate it in the discussion. Generally, rectal cancer, you have the early stage, locally advanced, and then recurrent, and then metastatic. We have an MDT. Like I said, we have an MDT. Tuesdays, a virtual meeting, Tuesdays, 8 a.m. And every cancer case, none goes to surgery without a full discussion. And then that full discussion encompasses endoscopy evaluation. We'll have some publications out soon regarding that data. All our cases undergo endoscopic evaluation and then have an MRI imaging. Now, in those meetings, the radiologists share their slides, and we thoroughly dissect the discussion so that we can stage appropriate patient. And then the clinical information has the ECOG. We use the ECOG status instead of the Kanofsky. And all the clinical information, the medical oncologists, the pathologists are in the meeting room, and a decision is made. So it's a multimodal decision, an MDT decision is made, and that is applied to. Sometimes patient doesn't go straight for surgery. Like I said, what we practice in UPTH is just what I presented, as it's all a mix of the stage of the tumor, the MDT discussions based on the evaluation, a thorough evaluation of the patient, and then standard surgery offered. As many that can afford the laparoscopic approach, that's limited, I must say, in this environment, going by the fact that even the rectal cancers, the numbers are limited, at least in my setting. So I don't know what I've addressed your question.
Yeah, thank you very much. Thank you so much. And there's a question here on the platform which I want to read. Maybe you've answered some part of the questions here already. Is MDT decision binding or advisory in your institution? When do you advise PET-CT scan for preoperative staging. And the third question, when is endoscopic third space surgery, such as ESD or endoscopic intermuscular dissection, indicated? And
Okay.
the fourth one, idea, where these are multiple questions. So I think let's address the first two, and then we can.
I had the last one. Let me start from the last, going back up, which is the endoscopic mucosal resection.
Yeah.
Now, early stage that's TIS, T1. There is two, not more than 3 cm in size, 2 millimeter mucosal malignant polyps. Those patients, malignant polyps, benefit from endoscopic mucosal resection. Now, when it's larger than 2 cm, yes, you can do endoscopic submucosal resection or do piecemeal endoscopic mucosal resection, but the tissue sample you retrieve, they are not good for the pathologist to analyze properly. So those are the cases that would benefit from the advanced transanal techniques where that is available. But I must say that most cases don't, that they are either locally advanced or metastatic. I rarely see early stage conditions. I don't know if I remember the other questions.
Yeah, the first one is the MDT decision binding or advisory in your institution?
It is binding. It is binding because getting all the eggheads in one place to reflect on different aspects of it and making a decision, it's not right to go against that. But we know that things can be dynamic, as the patient condition might alter from the stage at which the decision was made. We have a social media platform, a WhatsApp platform, where updates to the meeting can be made, and then everybody is still on board on decisions. I'll give you an instance. I was recently in out of the country, and the team made a decision, and some elderly professor felt he should reach me and then needed my own stand and all of that. And I kind of like deferred to the decision of the team, one not being privy to all the rounded discussions and knowing also that that's the right thing to do with respect to people who also are intelligent, who have spent their time and commented on an issue. So it should be binding. It's documented, and then in the template I showed, it has a place for the initial decision, and when a subsequent decision, that's another part to it. The first decision, there's no end to the number of decisions that need to be, a new number of times that a patient is brought to the MDT. It all depends on how it unfolds. So I encourage it to be a binding decision.
Yeah, thank you very much. Just to add, I think in these days of when people are becoming increasingly litigious, you need an established multidisciplinary team decision. It doesn't matter how predictable you think it is. You may even advise your patients in the clinic of what you think it will be, but with the proviso that you will defer to and the MDT. So it is mandatory really now as a colorectal oncological surgeon that if you have an MDT, you really shouldn't go outside the remit of the MDT. No matter how good you think you are or how correct, your decision might still be the right one, but it should be documented at an MDT that this decision have been taken. It just protects you. If things go south or you have early recurrence or anastomotic leak and people are asking questions, you could actually say, no, these decisions were taken at the MDT. It's just for your own protection. So I think we should defer to MDT and decisions, and where we don't have them, we should endeavor to begin to subscribe to an MDT to protect us. It's so important, just for your own protection. Before we go on, there are still a few questions on that slide, but Professor Shinowo, your hand has been up, so I recognize you.
Good afternoon, everyone. Sorry, good evening, everyone. Can you hear me, please?
Yeah.
Can you hear me, please? So
Yes, we can hear you.
Thank you, Professor, for your presentation. It's quite enlightening. I just have one or two questions to ask you. Case in point, one, you may have answered, I believe you answered one. How frequently do you see early disease? I don't see early disease at all. Most diseases that I see are locally advanced, and I don't dabble too much into metastatic disease. Most diseases, most of my patients have locally advanced disease, so they're going to have preoperative chemoradiation, they have surgery, then they probably have adjuvant therapy. So my question is, you spoke a lot extensively about resection, low anterior resection, anterior. How frequently do you protect your patients? Say you do a low anterior resection for a patient, do you protect with a colostomy or an ileostomy? Because you never mentioned that. I want you to answer that question, please. Thank you for your presentation again.
Thank you so much. That's a very good question. It was actually, will I say an omission, or when I checked the number of slides and I checked the time allotted, I thought 45 minutes, I could do 45 minutes and then give 15 minutes for any loose ends in my presentation for us to now have a discussion regarding it. Yeah, thank you. Low anterior resection. Now, we had a publication recently, a survey from surgeons that posted it on the platform on it shouldn't be routine. It should be selective, and there should be certain criteria, like the distance, how low down the anastomosis, if it's less than 10 cm, less than 10 cm, the tumor is less than 10 cm from the anal verge, if there has been radiation, if immunosuppression out in the West, where you have patients with Crohn's and inflammatory bowel disease and all that, who are on steroids and so on. So there are many surgeons go by experience. That's when you've had a bad experience, you now kind of like as a knee-jerk reflex, everybody, you know. But those stomas, they have complications. I mean, coming down from the, if it's ileostomy, you can have high output stomas. That's one of the most common causes of stomas requiring emergency admission. High output stoma, then other complications, and then where you have colostomy. Now, there's a study that shows about 45% of temporary colostomies end up being permanent colostomies. You know, so putting all that together, there is need for selective diverting stoma in rectal cancer surgery. Thank you.
Sorry, excuse me. Can you indulge me, please? Can you hear me, please? I need you to indulge. Yeah. Two things that you did say something that has to be selective, but increasingly in my center, we've realized one thing. Patients have had neoadjuvant chemoradiation. You must protect it. You must protect. When you do a low anterior section for them, you must protect your anastomosis with either an ileostomy or a colostomy. If you don't, you're going to have a problem. That's what we've realized in my center. I'm talking about Lagos University Teaching Hospital. The other thing I need to ask you, you did say that some patients have had colostomies, temporary colostomies, really have them reversed. I need to know why, please. Thank you.
Yeah, maybe can I just chip in there, maybe in partial defense of Professor Ray-Offor. He had actually mentioned exclusion criteria that for patients who have had radiotherapy pre-op, and those are some of the patients you will want to defunction or divert post, at surgery. And the other thing, again, we have to be careful. Many times, the defunctioning of an anterior resection or a low anterior resection just helps you to increase your number of reconstitution. If you're not going to defunction, then your threshold of creating a colostomy, an end colostomy, is higher. And then when we're talking about the likelihood of not being able to reverse a colostomy, this is when you leave a distal end, a distal rectal stump, and then you bring out an end colostomy. So the aim should really be to try and reconstitute the continuity of the bowel and then give a stoma. So most times for the colostomy, it should be a loop colostomy. If you're doing an ileostomy, it should be a loop ileostomy. So that increases your chance of successful reversal. But again, the threshold of individuals differ, and the studies haven't really shown any significant impact in terms apart from cost in our own demographics. In Nigeria, for example, if you are defunctioning patients, you have to consider the associated cost with that. And then Professor Offor also talked about the cultural nuances in terms of the stomas, and is it acceptable to everybody. So sometimes patient selections can also, or patients and choices can also twist your hand. So I agree with Dr. Shinombo also. When you have a patient has had neoadjuvant chemotherapy, the chances are that the vascularity of that area have compromised, and you have to err on the side of caution too. If you know that maybe your ICG and all that constitutes continuity, the function of the patient may help you avoid disastrous outcomes. I mean, they may not help you avoid subclinical anastomotic leak, but may help to avoid disastrous outcomes. Dr. Oyerobo, can see your hand.
Yes, thank you, Professor Offor. I just want to ask about the incidence of colorectal cancer in UPTH. I remember as far back as 2012, I was looking at ethnic differences in colorectal cancer in Nigeria. And I managed to get the cancer registry from UPTH online. And it seemed that you guys had less than 20 cases per year. That was 2012. Is it still the same, the incidence for you in UPTH?
Okay, I'm currently trying to do the analysis from the data I've accumulated since I came back. That's we started it 2023. So I could share that with you when that comes up, but what you have is what it was. I will share the updated version. I could do that privately, but what you have about the low number of cases per annum, that's correct. And that's why I recommend, that's why part of the, evidence has shown it that the increased volume of cases. I'll give you an instance. If you have 20 cases and you did LAR in 20 cases and you had anastomotic leak in 2, that is 2 over 20, that's 10, that's 10% leak rate, and that's high. But if you did like 50 and you had like the same number of 2, you see the index is the percentage is a lot more reduced. And that's what happens with data from the West. So sometimes some of us are shy to present our data because if you had any mishap, it will now kind of like not project you in the right light. So you want to accumulate more volume before you come out and make a statement. So I'll share our UPTH data, but what you got online is what it was then. Thank you.
Thank you.
Okay, and the other corollary to that is if you're quoting 2% or 10% of 10 or 10% of 20, those are your first 20, you know. So with accumulated cases, you find out that your learning curve has improved, your experience has improved, and the chances are that your anastomotic leak rate will progressively reduce. So the percentages will reduce with time. You know, so for you to have published that is very brave and very honest, you know, and transparent. And my view is that is, you know, there's, you know, the sky is your limit. There's only room for improvement. So you can't go below that because your experience will improve with time.
Thank you.
May I just chip in something?
Yeah,
I just want to chip in something. Yes, it seems to me, because part of why I was doing the study was find out that there might be something in the diet in the South that makes sure that your levels are low. Because if from 2012 till now, it's still about the same, like 20 cases per year, then maybe
I didn't say it's the same.
I thought you said it was just about it.
I said the data you have is what it was, but I'm collating our data and I'll share the analysis of that with you.
Yes, okay. I'm just asking for a ballpark figure. Like in a year, how many do you see now in a year? Because I'm still convinced more than 20.
It's a broad-ended thing. There are several factors that play a role in colorectal cancer. So to single out diet and say it's related to diet.
No, I'm still speculating. I just want to know that, okay, like I know in UCH, in Ibadan, we see like about 70, 80 cases per year. We get to operate on maybe about 40 or 45 because there's attrition. Like you said, some people don't want to have AP resection, but we do the biopsies and we get to know how many people have presented. Fine. Now, I know that in the South, there's a lot of, I don't know, palm oil dishes, a lot of fish, seafood. We need to be able to start to think about some chemo-preventive stuff, maybe that goes around that we're not even noticing. That's why I'm interested in knowing these ballpark numbers. That's all. I'm not saying it's the diet. I'm just saying.
Okay, sir. My point why I was hedging is this. Every locality has its own peculiarities. I believe in Ibadan, cases are in the West, in that area, are funneled to UCH. That's not the case here in Port Harcourt. There are several. I'm coming, sir. I'm coming, sir. Let me. That's in UPTH alone. I can tell you that the cases are about they are under 50 per year. That's if you want a ballpark figure. But I don't like citing numbers when I can patiently give you the accurate thing. Since I'm pushed the wall, I can say something like that. But what I'm looking at is trying to see the other centers that have standard care and try to have a larger number too, because without the numbers, you can't make meaningful statements, you know. So as regarding your question, in UPTH, the numbers are under 50 per year.
Okay, thank you very much. But,
Thank you.
Professor Offor, I take what Professor Rabo is saying there. He's trying to suggest that there might be something in the waters there. You know, a kind of meta-analysis of this might, you know, if you take his question, you know, considering diet, you know, will it be interesting to just include that as part of your meta-analysis to ask these questions, you know, in terms of dietary, you know, habits of this patient, you know, just a question, you know, to try and clarify his hypothesis in that area. It might be very important.
Well, we're open to collaboration. If sir has any proforma is worked on in Ibadan, and we can compare it with that in the south, that's doable.
Yeah.
But the point I was trying to make is that there are many factors to consider. There's the number that are less than 40, try to exclude hereditary, try to get an idea of the hereditary percentage. And then there are other risk factors. There are other risk factors. If you say for one, in this area, oil producing and all of that, affluence, fatty food and fast food generally and all of that, you know, the effect of obesity and itself, not the diet, but now the obesity. There are several other factors that actually the obesity factor is the one I'm looking at currently. I think in the SOGIM meeting next week, next month, I should have in Ibadan, sir. I should have a presentation if that's
Okay.
I wish I'll find it on that.
All right. Thank you so much. That was quite a robust conversation. I think those are the kind of conversation and interrogation we need in these meetings. I know I'm conscious of the time, Mr. President. If you would just indulge us, there are a few questions on the platform which I want to read out. Dr. Mukoro asked a question here. Thank you, sir, for the presentation. And those who have stage 1 and 2 rectal cancers and we're giving neoadjuvant, and this person's had complete response, where the tumor is not macroscopically or radiologically seen. Any role of surgery in these categories with new updates? If there is, how do we go about it with new innovation in minimal access surgery?
Okay, thank you. That's a good question. Permit me to use this to answer a question that I didn't. Something about PET scan, and it just crossed my mind now. PET scan. There are other investigative modalities but I just wanted to emphasize MRI in this presentation. Now, coming to PET scan is needed where you're suspecting recurrence, metastasis. That's when you go that far, because it's not readily available, at least in my locality, it's not. So it's not a routine part of our assessment. But when it's needed, we just have to share that with the patient, and then if they can go to Lagos and have it done, that will be fine. Now, early stage 1, T1, T2, there used to be that rave about endoscopic ultrasound, transanal endoscopic ultrasound, that's able to better classify the T1 stage compared to the MRI. But like I said, we hardly see this early stage. Now, I said the T1, where you have the T1 is not locally advanced. Is T2, T3, and the standard treatment for T1 is to have it excised. Now, T2, where you do the new adjuvants, and like I said, in some cases, you can have complete clinical response. Complete clinical response requires a full assessment that's endoscopic, take biopsy, do radiological assessment. There are ways to classify the response in following radiotherapy and all of that. So where you have a total response or downsizing, you still can do the local. There's a choice between local and then the radical, that's the TME surgery. But where you have a complete resection, a complete response, there's a place for watch and wait. But watch and wait is not something you just tell a patient and walk away. There's a responsibility that comes with watch and wait. There are series of evaluations that have to be done 3 monthly, 6 monthly. The patient should be committed to those evaluations. And then it is known that at least a third of patients who have a complete response ended up having recurrence. So all this have to be carefully explained to the patient in that's for the informed decision, you know. So there is a place to still have it undergo the surgery, undergo the standard surgery, and subject the specimen to pathological diagnosis, do watch and wait. But watch and wait requires a commitment to surveillance, and then because of the significant more than 30% risk of recurrence. I hope that answers the question. A good question. Thank you.
Thanks very much, Dr. Ray-Offor. And I know there are a few more questions from Dr. Mukoro, but I'll skip to get to somebody. And Dr. Iloba Njokama asked a question here. What is your opinion on single versus double staple line anastomosis for low rectal cancer? And how long would you wait following TNT, total neoadjuvant therapy, to assess patient's response if organ preservation is the goal in selected patients?
Okay, thank you. This kind of circles back to the conversation with Dr. Shinowo regarding radiotherapy. I'm missing out something. Please, can you say the question again? Sorry, please.
Yeah, so the first one says, what is your opinion on single versus double staple line
and the second
for low rectal cancer? And the second is, how long would you wait following TNT to assess patient's response if organ preservation is the goal in selected patients?
Yeah, thank you. I was on the right track. Now, when patients undergo radiotherapy, the tissue is edematous, and that affects the that increases the risk of anastomotic leak with the staple. That's you know, there's a height and all of that, you know. So the tissue are inflamed. Now, it's advised, it is known that after 6 weeks from the radiotherapy, you are more prone to scarring, which makes surgery so difficult. So within 6 weeks, and then you also know that radiotherapy, the maximal effect is not at it's weeks after you have stopped. So where I recently did had an experience, between 6 and 8 weeks is the ideal time. Now, this now comes to brings to fore the discussion on total neoadjuvant therapy, which aims to give all the chemo and the radio before, because many patients, if you leave it to adjuvant, they skip out. So the consolidation group, which is give radiotherapy and then give chemotherapy and then do surgery. That in the OPERA trial has been seen to have a better complete response compared to the other group. My thinking is that this kind of ensures that the radiotherapy is given, and then the weeks that are needed for the full effect of the radiotherapy are consolidated with the chemotherapy. And the patient surely, the courses of chemo will last weeks, So the patient invariably by the protocol now is having surgery about 6 weeks after radiotherapy. Definitely, they would have done restaging and all of that. Compared to the induction group where you give chemotherapy and then you do radiotherapy in a trial, some might not, some clinical setting reasons or something might make the surgery come earlier, than or later than needed. So that's the summary of what I'm saying is the 6 to 8 weeks after radiotherapy is ideal for surgery. And then where TNT is considered, the consolidation group is, the consolidation therapy is optimal. But in our setting where we don't readily have radiotherapy, we have tried to evolve our own protocol, which is supported by the Prospect trial, which demonstrate a 4-FOX regimen and then a restaging. Then if there is a response of where you have less than 30% response, where you have more than 30% response, then the patient can go on to surgery and then followed up with chemotherapy. But if you don't have a significant response, then such patients need to be referred out to center where radiotherapy is available. So that's a pragmatic approach that we have adopted.
Yeah, thank you so much. There are a few questions that are coming up with kind of modification, but let's stick to the script here. I have 2 questions here. I'm just conscious of time, but I think this is a topic I think we may have to revisit again with more time on the discussion. So I'll just enjoin the executive to consider that. Dr. Kunle, okay, made a comment here. I think this is more of a comment than question. And he said, if I had a high quality, cost effective, easily accessible IR backup or endoscopic techniques available to me in Lagos, I may be more selective. Unfortunately, I don't have that. So it is way more expedient for me to routinely defunction any anastomosis that is below the peritoneal reflection, including the stated exclusion criteria. Otherwise, I would have to take down more anastomosis than is necessary. Yeah, I think we all agree with your statement, Dr. Oke, because again, we have to play the opposition that is in front of us. This is I must commend everyone because you guys are really fighting with your hands tied behind your back, and you still getting good results. And I think sometimes rather than comparing your data with international data, this kind of caveat has to be stated, just like the modification Professor Ray-Offor is stating now, you know, to say, look, this is what we have, this is how we do it, you know. That the world can begin to recognize that there are other ways, you know, just a question, just a statement. And then the question from Antoinette, I want to really make sure that we acknowledge the questions on the platform before I hand over. Antonia says, are you seeing a high proportion of under 40s with rectal cancer in your practice? In our practice, we are seeing a number of patients under 40 years. What is your comment about this? If you can just answer that briefly.
Okay, thank you. Once again, as I rather work with my data, which I'm analyzing, but I have we're seeing a significant number of patients who are less than 40. In my collection, from the past endoscopic collection from the past 11 years, which I've been trying to follow up the patients and then have a crude survival, you know, from that, which is just in the neighborhood of 100, it's about 18% that are below 40 years. That brings to 4, and I must add that out of the number that were below 40, despite the counseling to the family that anybody who's at least 10 years below the index patient's age needs to undergo screening colonoscopy, not one, at least it came back to us for screening colonoscopy. So that's important statistics about our environment. Then the gene studies, which is another aspect to mention, where as we are primarily talking about surgery now, every related aspect should be upping their game. Gene studies are really not readily available. The last time I wanted to get into a study, I discussed with a professor in Lagos, and we have to talk about sending to UK, and for each, the staggering sum, you know, it's, I'm yet to get a grant to support that kind of thing. So it's not, I would say it's not available locally, because when something is available and is so highly priced to achieve, it's not readily available then.
Okay, thank you very much. If my memory serves me well, I think Antoinette, if that's, I don't have the full name here, I think she's from Ghana and she presented at one of our previous meetings. And if that is you, you're welcome. It just shows how far and wide these associations and meetings is spreading wide now. Thank you very much, Antoinette, for that question. And the final one, I'm getting red alerts here that we need to round up. The final one is from Dr. Enendu. It says, thanks for your presentation, sir. Please, which chemotherapeutic regimen do you consider the best in management of rectal cancer? And this is a very broad, so I don't know how you can summarize that in 3 minutes.
Okay, thank you. Just as we've tried to say in a nutshell here, that's the treatment should be personalized. There are a lot of considerations, and to cap it all is the patient's view and the patient's we don't pay too much attention to patient-related outcomes. That's patient's comfort. Now, to just jump straight to it, the Zelox regimen is convenient, where a patient comes in, a patient comes in and has the intravenous xaloplatin, that's with the pre-chemo meds and all of that, has the just has about 5 hours of stay in the hospital, and then goes away with Zeloda and takes that for 2 weeks, and that's convenient. Why I'm jumping straight to it is that the 4-FOX regimen, the prospect trial demonstrated that the 4-FOX regimen is equally effective compared to the modified for Forinox, and then the Zelox is like a sister to the 4-FOX regimen. But the medical oncologists, there are a lot more considerations to giving chemo regimen. But in a nutshell, pressed for time, I just want to highlight that aspect. I hope we can continue the discussion. Private chat me, we can continue the discussion on that. It's just time is no longer on our side.
Yeah, thank you very much. And I think we should carry on that conversation on the platform after this meeting, just to really delve into the multiple and the different aspects of chemotherapeutic management of colorectal cancer. So time is not on our side, and we want to respect your time also. So at this junction, I want to thank Professor Ray-Offor for that excellent presentation. And I think we all should go back and review his slides. They are very rich in information. And I want to thank all of you that took your time to join tonight. I think I'm really encouraged when I see the enthusiasm of everyone on this platform. So I will hand back to the president.
Thank you very much, sir. Again, I'd like to appreciate everybody for the patience and for waiting this long for the meeting. Also, again, we are very grateful to Professor Ray-Offor for the erudite presentation and for taking time to answer the numerous questions. And I know it was tasking. We are doing this for free, and because of your love for the society, we are indeed grateful. Just 3 quick announcements, and then we'll call it a day. Firstly, the recording of this presentation will be on our YouTube platform once it's been edited, so please look out for it, and we'll be able to review the discussions in there. Secondly, we will have the next meeting on the 29th of June, and it's from one of our international partners, Dr. Francesco Pata. He's an Italian surgeon. He'll be talking about recent trends in the treatment of hemorrhoids. And I've had a personal interaction with him, and it promises to be very, very exciting. So please let's look forward to it. And then finally, we have our mid-year OGM for the society on the 27th of July. And we'll communicate further details in due course, but just as a first announcement for us to be aware of this. Again, I'd like to thank us once again for spending time this evening with the society. And I wish us a lovely night rest and a wonderful week ahead. Thank you.